basic ureteric reflux and reflux nephropathy. In fact, one third of the urinary tract infection do have vesicoureteric reflux. Commonest cause of urinary tract infection is by E. coli, 80 to 90% as I told earlier. And this is again over here reflux nephropathy, renal damage. So what is reflux? The ureter normally is placed in oblique manner with a fold beneath it, and urine doesn't flow back when bladder contracts. But when this doesn't happen, ureter is a little bit small, placed in a straight manner without a fold. The bladder contracts and urine flows back into the ureter, kidney, and causes back pressure, infection, and renal parenchymal damage. That is what the reflux is. These children do have your hypertension, proteinuria, and your CKD, your recurrent pyelonephritic features. And if you do the DMS scan, you will get a scar. So, treatment of those cases is the your combination chemotherapy, and initially actually it is the shared decision. Benefit of the modalities of therapy: careful observation, watchful observation. One, two, your chemoprophylaxis, low dose antibiotic prophylaxis. Low dose means one third to one fourth of the standard or regular dose of antibiotic for the preventive manner. Two, three is the anti-reflux surgery, your implantation, reimplantation, and production of mucosal flap beneath the ureter, so that when urine doesn't flow back when the bladder contracts. And last one is the injection of sclerosing agent, deflux and others into the ureter, so that it acts like a bulb and urine doesn't flow back when the bladder contracts. So if but all the four modalities of treatment, they are not that useful at times. At a good amount of time they are useful. So benefit of the each there are the four modality: the watchful observation for symptom and security, and then two, your the antibiotic prophylaxis. Three is the deflux injection, and then for last one is the anti-reflux surgery. Reimplantation only. Reimplantation come mucosal fold production and oblique manner slanting placement of the ureter. All these four modalities, they are not always distinctly significantly different and useful. So, but they are useful in high grades of reflux 4, 3, 4, 5, and your recurrent urinary tract infection, febrile urinary tract infection, and ultimately have some usefulness in the scar formation and your CKD progression. So thereby, it is the shared decision. Talk to the parents and ask their views, which one they want to take, the benefit and the your risk, and then your modalities should be explained to the parents, and their decision should be implemented. So reflux may be secondary, maybe primary. In primary cases, you have some genetic genes involved over here. They can have some associations like MCDK, renal agenesis, syndromic like Better's, and and the renal tubular acidosis can be a presentation. Treatment of reflux, reflux nephropathy is ACE inhibitor, which reduces the proteinuria and hypertension, thereby reduces the progression to CKD. And treatment of the your constipation, and then treatment of the your bowel bladder dysfunction and association, they are to be taken, and then that to be considered. And resolution rate, the reflux resolution rate annually 10 to 15% is normal. So a good amount of time you wait, and then patient may improve without any sequelae. But 10 to 15% of the reflux do have your CKD progression, of which 20% will have CKD 5D. They need really end stage care.